Thank you everyone for joining our event tonight with Dr. Jim Thimons. I'm your host, Dr. Ariel Sorenzi. So I wanted to introduce our speaker that we were so honored to have. We were just talking a little bit before about how he's been all over the US and internationally speaking. And so Dr. Jim Thimons is a graduate of The Ohio State University College of Optometry. He completed his hospital residency at, I even practiced saying this.
Chillicothe
VA Medical Center. While at SUNY, he developed the Glaucoma Institute, which is a clinical research center, and served as its first director. He co-founded the Ophthalmic Consultants of Connecticut, which he is there now, and has provided over 200 publications in glaucoma, dry eye, cornea, and external disease. He's been a clinical investigator for multiple peer-reviewed studies, was awarded Optometry's top educator, and was selected as one of the top clinicians of the decade. And he's also helped to found the National Glaucoma Society. And on top of all that, was inducted into the Optometry Hall of Fame. So you're basically a celebrity. Well, thank you so much for speaking with us today.
All right. Well, thank you so much. Obviously, tonight's a discussion about compliance, colleagues, and I will submit in the beginning, this is arguably the most important thing we have to do. It is probably also the most difficult task to achieve. And I think at times it's also almost seems insurmountable to get patients to behave in a way that we understand is best. So one of the concepts that I'd like to spend just a minute or two with is understanding how this disease progresses and how bad it can be when we don't get good compliance, how rapidly a patient go on to blindness and then compliance, and can guide our patients to a lifelong quality visual experience in a disease where the vast majority progress. So if you look at this graph, this is the classic graph on significant vision loss. You know, if we can slow down their progression by increasing compliance, the best case progression rate, they probably will never be aware that that glaucoma has influenced their life in a significant way. The worst case progression rate, when they're poorly attended to, we saw many of these patients during COVID, they just fell off the face of the earth. They came back, they went from 2020 to 2,200 from glaucoma because they hadn't taken their drops in a year and a half. They hadn't been able to see us. So we had a very vivid example of this during this pandemic. And I've worked really hard to kind of recraft the office to get everybody on board on the train that says compliance is the order of the day. This is just a little concept of what happens in the glaucoma world. Now, I want to put forth, these studies were done prior to the onset of the availability of prostaglandins, with SLT as a primary initial therapy, which we're going to talk about tonight. So they represent probably a skewed rate, but trust me, I have a huge glaucoma practice, over 800 patients that I care for in glaucoma that I've developed over the last 20 years. And patients go blind, sometimes under your best effort. The patients who are more likely to do that are the ones who are non-compliant. This is Bob Weinreb's classic work. You've probably seen this. The goal here is to try to find the patient in the earliest phase of the disease and to initiate a glaucoma therapeutic regimen that the patient can adhere to and which will allow them to prosecute normal visual performance for the rest of their lives. This is just a little spin, and I think we tend to get a little into the weeds sometimes as doctors. We're taught, all of you were taught exquisitely well at your institution, I'm sure. And as a result of that, we look at these and we say, oh, okay, that's where we are. We have an early nasal step, where we have a gerum that's beginning to deepen. Oh, we have a double gerum, which is, by the way, a very bad sign. But this is our perspective. It's visual fields, it's OCTs, it's IOPs, it's corneal hysteresis, all of the factors we blend together with the diagnosis. This is what happens to the patient. This is what their perspective is. Ours, somewhat cold and a little bit isolated. Theirs, very real. And when we get to advanced glaucoma, they have lost a tremendous amount, even in a slowly progressive process. But even there, when you measure a visual loss at 24 in a 30-2 or even 24-2, you can assume that that loss extends all the way out to the edge of fixation, to the end of visible vision in the peripheral field. We're only measuring the central 30 because of the fact that if we had to measure everything, you'd only get one patient a day through the office. As I said, we rely on some very objective findings, which are important, they're critical, but the subjective part of this, which is the patient, the functional aspect of the patient, is really crucial as well. And sometimes I think we lose track of this in the process. One of the issues with compliance is in a busy office, or when you're seeing complex patients, it's really easy to lose the conversation about compliance and, more importantly, quality of life. What is quality of life? And that's the goal here. Compliance is a direct, linear, preceding element to quality of life. How do we give our patients great vision, or the best vision possible in glaucoma? Glaucoma is a powerful disease. If you don't believe that, just look at these studies. I mean, the SIGIS study, 15% of the patients in here reported significant fear of blindness. And, if you treat enough glaucoma patients, you know this as well as I do, you will have patients, colleagues, who first thing they ask you is, am I going to go blind for this? It's a real question, and we need to have real answers. And one of the ways to position that answer is to help them understand that with a combination of medicine with every patient in your lifetime, I will use a combination of medicine and surgery along with my partners to blend together a treatment program that is going to allow us to help you control this disease and give you good vision for the rest of your life, or until we find a cure. And they love the fact that you're there for them. And I also firmly believe that compliance increases dramatically when you buy into their side of the argument, which is, I'm afraid I'm going to go blind. And as you know, patients who have bad diseases sometimes try to ignore them because they don't want to deal with the reality that's present. These are some early studies. This is out of Goldberg, Ivan Goldberg, out of Sydney, Australia, looking at results on quality of life in our patients. Why compliance is important. We want to maintain the best quality of life possible. So if you look at his early results, patients with glaucoma, beginning, moderate, and advanced, all had poorer life levels as far as quality of their lives. Particularly poor is that mesopic light level, where patients have trouble walking. There's data on increased risk of fracture with falls, when one falls. We're going to talk a little bit about driving here. I mean, look at this right here. When you have a 30-degree field, you can pretty much see everything that's important to you if you don't change your position of your head. But look what happens at 20. You're starting to miss that car to the right, that bicyclist to the left. You get down to 10 degrees, and obviously functionality should go. I question the viability, because when you put a patient into that setting, there's so much information that's not getting processed. I know that within the patient's lifetime, we'll see progression. That's going to happen. I'm perfectly comfortable with that. But my goal is additionally to make sure that progression tries to stay within the zone. So if they start in mild glaucoma, I really want to prevent them from getting into mid-moderate. If they start at late mild, I can accept the fact they're probably going to get into moderate, but I want to maintain the field the best I can over time. How do I do that? Compliance. This is an interesting subset. This is a Latino eye study. This is the largest study of the Latino population in the world. It was done in LA about 20 years ago now. So you can look at the results here on the NEI visual function quality of life test. There's a 25-question test that they have. The driving subset decreased considerably, as you can see on the graph, as the disease increased. So as the disease worsened, the ability of the patients to drive, or their willingness to be comfortable driving, markedly decreased. And if you think about driving in the United States, driving is kind of a birthright here. I don't know how many of you have had to take away a driver's license because of legal blindness for whatever cause, macular degeneration, retinal disease of other types, glaucoma. That's usually a much lesser number, but it's a very difficult conversation. It's an easier conversation, by my perspective, to put the patient in the driver's seat, as you will, by letting them know that if I can count on you to do this, and if I can rely on you to be that person who's going to take your medication, and if you don't, be the person who's going to honestly tell me that you're not, then I think we can craft together a big protocol for you over time that's going to allow us both to succeed. And I have these conversations regularly. I spend as much time talking to my patient as I do gathering information. Fortunately, I work in a setting where the information gathering is done by other highly talented individuals. My techs and my fourth-year students we all work together as a team. And the students are standing there right with me, listening to every one of these conversations. And sometimes they're difficult, sometimes they're heartfelt, sometimes they're tear-laden. But the reality is I do have to have that conversation several times a day about compliance and the reason that compliance is important. And you reactivate their enthusiasm and you talk about other options, which we'll get to before the end of this lecture. This is just a really interesting study on 2005 study that looked at the risk of collisions. You can see marked increased risk of collisions when the visual field comes below 24 degrees, markedly increased. I think this is critical for us to look at the visual field as an indicator of long-term viability of the visual system. And in this particular case, when I see a patient rapidly progressing like this, there is no question medication is pretty much not the order of the day. They have to move to a surgical endpoint. And we'll talk about how we can improve compliance with new technologies as we go forward. And this is just some mobility issues, notable. Think about this. This is the analogy I give my patient. When you were 25 years old, you could ride a bicycle when you rode bicycles, and you could fly down the street at 15 miles an hour and the traffic's whizzing by, or you're going by, making turns or going uphill, downhill. You're constantly making visual decisions because your brain is being fed a full diet of visual information. That same patient, if they had a visual loss related to glaucoma, let's say at age 45, even if they could still ride the bike and they had a 20-degree field, you're missing 70% of the visual information. And as a result of that decreased processing pattern, you are much more hesitant. You are much more withdrawn in your day-to-day behavior. You can see here, just on average, they walk discomfortable in their space. They have to look down. They have to move around. My goal is to never have to deal with this in the office. But I think it's crucial for us to understand that this disease does have long-term progressive change. So what are some of the factors that can help us predict who needs to have the best compliance? Because not everybody is going to go blind from this disease. 90% of the patients do not. Only 3 to 10% do. Who are those who are most at risk is one of the ways to invest both yourself, the energy of your office, conversation with those who are at the highest level. So let's talk a little bit about the work. This is Asrani's classic work. Sanjay Asrani is somebody I've known for a long time. He's lectured at the NGS for us. He's a terrific clinician, a great researcher. He was the first person to identify this diurnal fluctuation issue, which I think is absolutely crucial. I can't imagine not understanding this moment. So patients with the highest diurnal, as you can see here, had the most stable vision. So if you want to predict the future of a patient, if you see a patient, two patients, let's say, the range was, let's say the average pressure is 18, make it that. If one patient has an average pressure of 18 by having a pressure of 12 at the low and 24 at the high, and the other patient has an average by having 16 and 20, the patient who's 16 and 20 is much less likely to progress, as you can see here, than the patient who has that same average IOP of 18, who has a range of 12. So the higher the range, daily range, that's why we collect multiple readings before we initiate therapy, the more likely the patient is to progress. This is an established fact. When I initially work a patient up and we bring all the data together, this is one of the factors I look at, and it's how I choose my therapy, whether I start early with a single medication or whether we initiate with surgery. And I do that a lot these days. I've really moved towards a much more aggressive position, having had a lot of experience with patients not complying and seeing progression under glaucomatous therapies that are effective normally, but when the patient doesn't use them, one of the new concepts is take the meds out of the hands of the patient to some degree. So this is one of the areas that we have to look at. Adherence is another. Let's just admit the fact that our patients are not going to be any better than the patients in this trial published in 2001 in the American Heart Association monograph series. This is a classic study. Of the average well-controlled, and I put that in air quotes, hypertensive patients, only 50% of them take their doses on time. More than a third drop out of care in the first month. In long-term clinical trials, adherence is no greater than 80, and it's no lower than 40, but somewhere at about 50%. I'm going to show you our data from the ophthalmic side here in a second. Compliance to health-related behaviors, eating, addiction, gambling, less than 10% long-term. So let's take a look at us. This is us. This is one of the great studies. Friedman, Harry Quigley, out of Wilmer, Nordstrom, published at AJO, 2005. This particular study struck me probably more than any other study I've ever read relative to adherence or compliance in our space. You look at the prostaglandins, and you look at months after treatment on the x-axis, and on the y-axis, you look at percent. At about a year out, you're right around 45% adherence with a single drug. The moment you add another drug, you drop down almost 50% from that to 25%. So if you look at this, it's such a, after that, they fall off the edge of the earth. When I see my patient at that 3-month visit, that's when you have to reignite the process, because we know from this data that they'll hold on for you for a good while, probably about 3 or 4 months. And then they start to fade. And as they fade, then we all go away. So this is something called an MPR. This is some data from a different study. And what they do here is they take the daily doses of the dispensed meds over the days between initial prescription and refill. It's a very sophisticated analysis, requires some simple math, but it's nice, it's very accurate. Here you have MPR at 50%, which means you have a 40-day supply and the patient took 80 days to refill it. So they took 50% of the time. This is the average retrospective pharmacy claims, data and survey patients over an entire group of individuals, 13,000, almost 14,000 patients. Crazy numbers. Look at that. Survey patients, average about 0.6. So that means 40% of the time your patients aren't taking their drugs. I'd say that's fair. I always teach that it's about 50%. I think that's a fair number. But both of these studies show us something about our space that are particularly important, and that is our patients are no better than our colleagues' patients with hypertension, diabetes, any of the chronic diseases that require daily management are difficult. This is another factor that's an issue, probably more than most of us understand. There's cost involved with this disease. Even when patients are on generic drugs, colleagues, there's still cost. There's cost of taking time off work to see us. There's cost of taking time away from their family. Some of them may be key providers. They may have babysitters or other individuals fill in behind them. There's a cost to that, either in real time, in time cost, or financial cost. But this is Paul Lee's epic work. Paul was the chair at University of Michigan when I think he published this when he was there. I'm pretty sure he did. I'm pretty sure he was there. He's moved on. But great study, 151 patients. A glaucoma suspect cost about $623. That's mostly office costs, right? An end-stage patient cost about $2,500. Now, take this forward today, you could probably triple those costs today, or at least double them. Well, probably more like triple. And you can look at the bottom, medication cost is 24 to 61% of the total. So when medications start taking food off the table, when medications, and you all have this, there's no way that you're not part of this discussion daily. Doctor, I can't afford that drug. So do you think they're really taking it when they're telling you that message? That's a lesson that we have to take out of this discussion tonight and hopefully translate into a better communication pattern between us and our patients, which is the one tool that we really own as physicians that we can implement every day is the ability to be a clear listener, an empathetic individual, and a person who can educate and motivate our patients to continue the journey of a long-term chronic disease management program. This, to me, is one of the biggest hidden factors in assessing long-term visual success, or in this case, compliance, is cost. You know, patients tell me, oh, I just ran out last night. I hear that sometimes 5 times a day. That's code for, I didn't buy it because I actually preferred to eat last month. Because we're not, typically glaucoma doesn't stand by itself. It's not a one-off individual as far as disease. Almost always glaucoma is associated with other systemic diseases. So we're not the only cost point they have. And as a result of that, you know, we have to look at this overall cost structure and how we impact the patient's compliance by bumping up the cost to meet our goals, but trying to maybe not balancing it with the patient's life goals or life capabilities. So very important discussion. Corneal hysteresis, maybe the most significant new technology that occurred about 10 years ago, was the ability to predict progression in glaucoma. This is Neil Congdon's original work out of the AJO in 2006. He was at the Wilmer at the time. He basically showed that corneal hysteresis as a predictive value was far greater than CCT. I'm sorry, I'm missing a line down there. Actually, it should say 0.3. I can't address that now. So it's 0.03 versus 0.3. So the bottom line is CH. I don't know if it was highlighted, somehow it disappeared when we changed the slides over. But that's 0.03. So it was 10 times more sensitive than pachymetry. Matter of fact, it was so sensitive that it actually knocked out pachymetry in this study and became the dominant predictor other than age. So powerful tool in predicting who is going to progress in glaucoma. That has been then taken forward. By the way, the reason it's so powerful is this. You know, in pachymetry, if you think about it, I have patients from South Asia, routinely packs in the low 500s. I have patients from West Africa. Some of those individuals have packs in the 400s. Somalia, Ethiopia, Bangladesh, 450. I have patients who are Caucasian, 590. These are all pachymetries from patients who don't have glaucoma. So as a predictive tool, when you have a range that large, it's very hard to use a single number and say, oh, this is thick, moderate, or thin. And in fact, I don't. The best I'm going to give you on pachymetry would be, it's thick, there's some protection. It's thin, there's more risk. It's moderate, it's a push. Here, with corneal hysteresis, very interestingly, if you go around the world, it's the same everywhere if you're normal. So any variation from this normative database that's worldwide is significant. And if you look here, this particular graph, this is the Kaplan-Meier curve from Felipe Medeiros' work in 2027. Yeah. And that curve shows you, sorry about that, that curve shows you that patients who have lower than average corneal hysteresis are 300% more likely to go on to develop glaucoma. And I already showed you Congdon's curve, which is almost identical within glaucoma. So this becomes a really powerful indicator of how high you have to set the bar as far as goals, or conversely, how low you make the goal pressure in order to achieve the disease state endpoint that you want, the management endpoint. With that, there's a price. The price becomes compliance. I could give everybody 4 drugs, and so could you, and we'd end up in a good world, but we'd also end up with about 100% compliance. So we have to balance that so delicately with glaucoma. It can be done. It can be done very effectively. I'm going to spend just a couple of minutes with high-risk optic nerves. So optic pits, this is a work by Rob Stutman. I am absolutely delighted to tell you Rob was one of my really smart students at SUNY when I was department chair there. And he has maintained a really beautiful career in the state of Baltimore. Terrific guy. Without a doubt, this is an important finding. If you see an optic pit, your patient has much more likely to have a progressive optic disease, optic pressure. Peripapillary pigmentary changes, you've seen that as well. That's not unusual. So the peripapillary pigment changes, these are the alpha zones or the alpha and beta zones of Jonas. And in patients where this is progressive, this is not for patients who have, peripapillary atrophy from myopia that's prior to glaucoma. This is for patients who had no atrophy and developed atrophy. You can see that the alpha and the beta zones are indicative of significant risk for glaucoma. If you see this type of progression, you need to alter your treatment pattern, obviously. And more importantly, you need to have a long and I think really meaningful discussion with your patient about the simple fact that we need to improve compliance. Disc hemorrhages. Anytime you see a disc hemorrhage, fact, this patient's pressure is not at the level that you need it to be. You have multiple reasons that might happen. Disease may be worsening. The patient's systemic status may be declining, or most likely they are non-compliant. This is a great identifier of non-compliance. I automatically up the ante considerably every time I see a DRANS. The loss typically occurs at a later point, 2, 3, 4, 5, 6 months later. So I would do a baseline that day, or that immediate time period, do a second field at about 3 to 4 months out. That'll tell you the more significant impact from this particular event. Discount ranges, as you can see, overall prevalence is really low. In patients with glaucoma, it's about 10 times higher. Now you can look here, low tension glaucoma, it's almost pathognomonic, but it also occurs in elevated or normal, POAC. The key is anytime you see it, it indicates that there is absolutely a lack of proper control due to one of the 3 things we just mentioned, most likely compliance. This is just Healy's article in the journal. And here's the prevalence in men and women. Women are much more likely to show these schemes at every age, which is not uncommon. This is Doug Budenz's work. Doug was the chair of Doug Anderson. They were all done at Bascom Palmer, one of the great ophthalmology, Richard Parrish. I mean, that trio there, Parrish, Budenz, and Anderson, wow, what a great day for Bascom Palmer glaucoma. They were the kings. Doug Anderson was one of the early individuals involved in understanding the effect of systemic blood pressure, which, by the way, if you look at this article, one of the biggest concerns you have as far as predicting future behavior, and one of the real risks we have in controlling even well-compliant patients, is your diastolic blood pressure. I strongly recommend that before you start the journey with every patient, you should give a standard BP at the chair. And I check it periodically. If it's relatively normal, if they're being treated for hypertension and it's in the range. But I'm looking at that, size 2 to 4 female, a little longer in look. They look very athletic. I call them aesthetic. They're classic for a normal tension or low tension glaucoma patient. Those patients need to have blood pressure measurements regularly because their nocturnal hypotension, in combination with the elevation of IOP that we've seen in many studies that takes place in the night, is really the progenitor of their progression. So for them, compliance can be at 100%. They can get worse because the underlying problem is not their IOP so much, but their blood pressure. So I work directly with their internists, family practitioners, cardiologists, whoever they have, in raising their blood pressure generally to a level that we can all accept. And you will see a notable decrease in their perspective, in their progression. This is the old study we talked about for chemistry. I'm not going to spend a lot of time on this, but the 5-year data shows that there's no question patients with thinner corneas are more likely. Unfortunately, in this study, there was a preponderance of Caucasians, very few Asian Americans, almost no South Asians, no Africans, nobody from the diaspora, which is the Fertile Crescent in the Middle East. So we're missing large population bases that we now know have a different pachymetry size. So in our patient base, this is a US-based study, this works well. But as I said, corneohysteresis is better. This is the final one I'll talk about. This is the new treatment paradigm. This is amazing. I've taken this on for the last 2.5 years. Understanding patients' tonography or their outflow mechanics is essential to predicting both disease state, disease progression, but more importantly, to understanding the truth about compliance. I'll simply leave you with this analogy. And so it's a big subject to take on, but it's important to understand that it's there and you can access this. The device looks like this tonographer here, attaches where your slit lamp works. But the key here is this, Collins. This is the A1C of glaucoma tonography. Intraocular pressure is like taking scattered blood sugar readings throughout the day. They're relevant, but they're not particularly helpful. This is the A1C. If that number is below 0.18, or if you see that number falling while you're treating a patient, you have one of two options. The patient is either worsening their disease state, or once again, more likely, they're not taking the medication. You may not be catching that in the form of an IOP spike because the patient may have some residual effect of the drug, or you may just hit them at one of the troughs during the day. But this is insensitive to that variation. This gives you like that 90-day moment that says, this is where your patient's at. And you put them on this drug and it worked really well to increase outflow. I am much less concerned. As long as they keep that outflow number where it's at, I'm happy that they're compliant. I know they're compliant. I understand that. It's when that number starts going down that I understand that they're not compliant, or as I said, the disease is worsening. So very powerful tool. It's called the Falk Medical Multi-System Analysis. So let's talk a little bit about identifying and addressing barriers to adherence. We probably have enough time to finish this out tonight. So, there are 5 basic things that cause us to understand why patients don't adhere. They are threatened by the illness. They don't understand the benefit of treatment. As we talked earlier, the burden of treatment can be overwhelming. Patients on 2 or 3 drops, 5, 6, 7 different drops a day. If you think confusion reigns, just give a patient a verbal instruction who's taking 3 different drops in the exam room without writing it down. Walk them up to the front desk. And if anybody here can achieve at least 50% of those patients walking out in a clear state, I will buy you dinner anywhere in this country. I literally can't make 20 feet sometimes, and I've spent 5 minutes talking to them. What do they want? They want it written down. So we have this really nice sheet, and I'm happy to send one forward to Stephanie, Dr. Wu. It has all the glaucoma meds. It has how many times to take it. Even that, I get a phone call about a day later. It says, I'm a little confused about these drops. Glaucoma in and of itself is a disease that decreases cognitive function eventually, increases depression, increases sort of memory issue, or decreases memory availability. So it's not surprising that this happens. The other thing is patients they're confused about when to do it and what to do. And then there's social and instrumental support and resources. They have to have the family member is crucial. I love it when somebody in the family takes the responsibility for being there with their parent or their aunt or their uncle, or even just their next door neighbor, and is a good soul, somebody who has a committed level. I talk to them sometimes a little more than the patient because they need to know. They're the ones who will keep reminding the patient. When I have that 88-year-old walk into the office, male or female, by themselves, or they got left off at the front door, I know that's going to be a tough compliance patient simply because all of these things are going to hit and I'm going to get a phone call. So what do? I give them my personal cell phone number and I say, can you have your daughter call me? And they'll call. And I have a conversation and I clear up what we did, if we made changes, if we didn't, how well they're doing. Those are critical to all levels of compliance. So let's talk a little bit about, all right, that a patient's non-compliant. So here's the most common approach. Have you been taking your medications, Mr. Smith and Mrs. Jones? Oh, yes, doctor, I take my medication. Now, they didn't tell you how often they take it. They don't want to lie. They don't want to be a prevaricator. But reality is that they probably aren't taking it anywhere near the level that you want them to. You've basically had an open-ended question. All right. So when my students ask this question, and they routinely do because they haven't had the experience of asking questions in the right fashion, I will say to them, motion denied, you are leading the witness. You're leading the witness here. This is an obvious yes answer. They're not going to tell you no, ever. So we understand that behavior is repetitive. It's not just in our space, it's in all spaces. Therefore, we need to monitor or create our questions to help understand the patient better. You begin with an open-ended, direct question. Tell me how you take your medications, Mr. Smith or Mrs. Jones. Or something simple. How many medications are you taking? You know they're taking 2. Something even more simple. What color are the tops of your medications? If they're involved and they're even reasonably compliant, they'll know that they're taking a purple and a green or a yellow. All right. So thankfully, they're color coded. That makes it much easier, or an orange one. So you reverse the judgment environment. Reassure that non-adherence is universal, normal, and understandable. I'll explain that in a sec. You need to enlist the patient's active participation. I need to know as clearly as possible what you're doing. because my decisions today are going to be based on whether you're taking your meds regularly or not. And if not, we have one thing we can do. If you are, then I have another path that I need to follow. Both of those are important so that we can help you keep your vision for the rest of your life. And then the whole forgetting or missed medication thing. So question one, how do you take your meds? No. Are you taking your medication? No, never. How do you take your medication? Yes, good question. Following up about the patient's personal strategy. Show me how you do that. Every once in a while, I have a patient who swears they're taking their meds, pressure's rising. I don't think the disease is worsening. I think they're just not getting the meds where they should be. So we get a bottle of artificial tears, bring it in the room and say, Steve or Helen, can you put that drop in for me? Let me take a look at you. And when they put it in, if it's really bad, I'll video on my phone and I'll show it to them. And I say, look, this is what you're doing. Let me have one of my techs work with you on getting the drop in better, because I know you've been great about taking it. Now we just need to make sure that you take it and actually get it to where it makes the most effect. Okay. And then the other thing, and that's the bottom bullet, absolutely every glaucoma visit, if you can, get your patients to bring their drops with them. And then say, how often do you take this one? When do you take this one? You'll be surprised. Some of them are taking their prostaglandin 3 times a day, and they're taking their dorzolamide once a day, or maybe they're taking their Comagan once a day, and their Lumigan twice a day, which is quite bad, by the way. I don't know if you know that or not, but prostaglandins, if taken too much, have a paradoxical effect. It can raise IOP. So while you perceive that as non-compliance or increased disease, it's actually a medication error secondary to their inability to understand what they're supposed to do, which is a compliance issue. Reverse the judgment, normalize and universalize. I tell all my patients, look, I know it's difficult to take these drops. I don't know if I could do it, and I understand what the end point of this is. So, I need a reasonable perspective on how often you think you're getting them in. I know it's impossible to take all the time. Once you get them off of the guilt side of this, I think you'd be pleasantly surprised by what you get back from them. They're pretty honest. They'll say, look, doc, I probably do it maybe 2-3 times a week. Okay, I'm good for that. That helps me interpret where we are today. And then the next question is, did you take it last night? And they'll go, you know what, I don't remember. Or no, I didn't. Or yeah, I absolutely took it last night. Okay, I now have another piece of information to help me with my assessment of your compliance. Third question, make sure the patient's an active participant. Sometimes, honestly, with my very senior patients, that's hard to do. But in patients who are in that 55 to 75 range, most of them are very capable of having a reasonable conversation about what their responsibilities are and how to prosecute those actively. And then finally, missed doses. All right. So the most significant active predictor of progression in the disease is lack of compliance. That was Paul Lee's classic study. He showed that missing 3 consecutive visits or having reported 3 consecutive episodes in different visits and consecutive visits of missed dosing is the most likely way for your patient to go towards blindness, which is all about adherence and really the bottom line of compliance, which we've been talking about for the last 40 minutes. So this ability to understand when they're missing is going to change the whole perspective. And we're going to talk about that right now. Clinical management to increase compliance. We have a couple new therapies on deck. Everybody's probably used them. I'm not going to spend a lot of time on them. I just want you to know that if you look at that prostaglandin list, right? If you've put that patient on a drug that's a standard prostaglandin, which we've had for years and which has worked very well for us, and you don't get what you want, it is reasonable, if they do not want to undergo surgery, to switch over to Rocklatan and or Vyzulta. And here's why. Okay, it's not that the other drugs aren't effective. They are effective, especially drugs like Lumigan, very effective. But when I reach the end of that road and I have a pressure above that number that I need to get lower, and I don't want to add a second drug because I just showed you what that does to compliance. I want to stay single drug therapy. I'm going to do this. I'm going to look at this and I'm going to say, the data from the study, the Mercury study, shows that in comparison to latanoprost, this is standard Xalatan latanoprost, not generic, that this drug is in the higher numbers. So if I want to get that extra 2 or 3 millimeters of mercury, I can do that almost routinely by having the patient try another drug. The worst that's going to happen is in 3 weeks, you're going to find out it doesn't work, and they're going to move over to a surgical option. That's the pathway. But you have a really good chance that you might get that extra 2 or 3, keeping them on a single med, increasing your compliance and decreasing the potential for irritation. Now, here's one of the problems. Drugs like Rocklatan and Repressive, but Rocklatan since the most commonly used, they have a high rate of conjunctival hyperemia. When drugs have significant side effects, compliance goes down. It's that simple. Nobody wants to look bad in the morning. Nobody wants to have to deal with it every day. Giving them Lumify is a short-term solution, quite frankly, colleagues. I love Lumify. I have it in my briefcase. I keep it in my travel kit. Great drug. But I don't want to use that every day if there's other options that will help me get to where I want to be without that. Now, the same data that you see here holds true for Visoltra, latanoprost, Bunod. Here, they achieved that 3, 4, and 5 above Xalatan. And this is real Xalatan, not generic, in 30, 20, and about 10% of the patients. So I will always make a in-class switch to a dual therapy drug, i.e. Ropressa and latanoprost, or Tardicil latanoprost, and or nitric oxide latanoprost, before I move into a surgical option, if in fact the patient has any pushback. In many instances, I don't even try this. I just go right into a surgical option. And I've found that that's not ineffective. But I think there's reasons to pursue this path, because for the majority of patients in this country to this date, they still want to do single drug therapy or do drug therapy before they move into a surgical arena. This is the side effect profile with Visolta, which is particularly low. So it's a drug that works really well in this space, but they both have good IOP control, and you just have to pick what's available for the patient from a cost perspective. Many of them, by the way, are not covered. Let's go to this. So this is the light trial. This has to do with lasers and glaucoma management. This has changed my personal practice as much as any technology that has come about in the last decade, or knowledge, I should say, not technology. We've always had the SLT. What's it do? Well, what it does very effectively, it shows unequivocally, colleagues, that it is a first-line therapy versus medication. So why is this a reasonable point of discussion within a compliance setting? Colleagues, we're taking the drugs out of the patient's hands. I just told you and showed you, I think, hopefully unequivocally, that the patients, even at their best, are maybe 80%. Probably at their worst, they're closer to that 40 or 30% that we saw in the trials. Here, at 3 years out, 75% of the patients, approximately equal to the number of patients in the trial on the medical side, were able to sustain a controlled IOP at goal level without additional medical therapy. That's tremendous. So my current conversation when I start a patient or when I see a patient who's back is, we have new data from an outstanding clinical trial comparing medicine to surgery, i.e. laser. That study shows that the laser is just as effective as the surgery when it's used early in the disease and can be repeated. And in 75% of the patients, we can typically relieve you of a single bottle of medication. Now, this is not for a patient who's end stage. We use it for that, but expectations there are much more guarded. You're not going to get rid of 3 medications with a laser. That said, you might be able to get rid of one of them and therefore increase compliance and decrease side effects of the drugs and topical toxicity. This has become the standard choice. I'd say right now, minimum 50%, probably closer to 60% of my patients are selecting laser first. I'm fine with it. I'm there for them. I understand that we spent a career getting glaucoma meds into our hands, and they are still a very, very important part of the overall therapeutic agenda. But the cold reality is this data is absolutely incontrovertible. This is a great way to start the journey if a patient wants. One of the things you can do, and this is sort of the twist that I put on it, there's a study by Alvarado that shows that persistence is or response is related to type of molecule. So he looked at trabecular endothelial cells and Schlemm's canal endothelial cells in his study, and he looked at them in vitro. So he looked at them in a test tube, right, or in a petri dish. he stimulated them with different drugs, and he watched how the cellular junctions acted. So for beta blockers, alpha agonists, and CAIs, they were all different. For laser and PGAs, they were exactly the same. So from that, you can deduce that if you have a good response to a PGA, you should have a very high probability that that same response will be elicited from the laser. And so I tell my patients, we have two ways that we can do this, A and B. We talk about that a little bit. And I'll say, look, if I start you on the drop and we have a good response, then I know when I see you at the 3-week visit or the 4-week visit when you're coming back, that we can talk about the laser if that's what you'd like to do. Because if you have a good response, we can usually duplicate that with the laser at a very high level. If you don't have a good response to the drug, then the laser is probably not where we want to go next, at least not immediately. And so you have a really powerful piece of information that you have. And this is the backside of that study, which is repeat laser. So again, we did lasers originally, and when they didn't work, we said, no, we're not going to do that again, or won't do it for a year and a half. This study says, go ahead and do it again right away, because here, 70-some% of the patients at the end of that second treatment were able to achieve goal pressure simply by adding more laser to the process. So this is the new horizon, colleagues. This is a product by Allergan or AbbVie, which is absolutely fantastic. Love this. This is another way to take medication out of the hands of the patient. This is a sustained release product that is called Durysta. It's a intraocular element that's implanted into the eye via injection, the way our retina colleagues inject, Avastin or Eylea or Lucentis into the eye. And what happens is that element sits there and slowly elutes the drug over a period of time. The data from the study was excellent. It showed outstanding control. This is the injector. This is the implant device. Here's the data from one of the studies. This is the Durysta study in March of 2020. So it was just released during COVID, actually. It's the Artemis 2 study. So the data shows that at 3 months out, the Durysta is still superior to beta blockers, but by 4 months out, it still has a really good effect. I mean, the original IOP was almost 25. The patient's down at 18 and a half, so it's a good response. It just isn't quite as good. So it starts to fade somewhere around the 3 to 4 month place. Many of the patients we have last all 6 months. Right now, there's a limit on how many times it can be done. It can be done once, simply because of the risk of endothelial cell dysfunction that may be associated with having an element in the eye. They're looking at that data. They have a second set of trials which are actively looking at second injection response and second injection complications. I strongly anticipate that's going to change the dynamic. I love this drug. I have so many patients who are struggling with getting it into the eye. They can't afford the cost of it. I want a drug like Bimatoprost, which has had a 20-year history of outstanding control, to be the drug of choice. But I can't get it to them. We're having toxicity. There's so many issues. This is a great, and I hate to phrase this, it's a bad way to describe it, but it's actually an interesting thought. This is a gateway drug. When I take that drug away from the patient and they can go 6 months without it, their eyes whiten, their vision improves, their overall sort of management view, it just improves. It's amazing how the patients love not having to deal with those issues, right? And that makes it an easy patient to transfer into a laser the next time and say, look, we had a great response to the drug. We're not going to put a second one in right now. Why don't we do a laser? And let's see if we can get a few years out of that to continue to control. This is the future. There are so many other drugs out there with this concept, right? I'm going to spend 2 seconds on this. This has revolutionized visual fields in the office. And I know you say compliance. What's that got to do with visual field assessment? It has everything to do with visual field assessment. How many of you have said to a patient, oh, I'm going to schedule you back for a visual field next time? The patient goes, do I have to do that again? I just did that. And then you look and it's been 2 years. Their memories are like elephants when it comes to the torture chamber, which we invented back in the day when we made a bowl and we started flashing lights in it. This is a virtual reality system that has revolutionized my visual field assessments. Patients say, oh, yeah, I'll do the visual field. That's fine. Come on back. I can pop this into any room. I can put the patient in a waiting room if I want to. It runs independently. It is able to do adults. It is the only FDA-approved pediatric visual field. It also does other things like visual acuity and color vision. Love this system. This is called All Eyes, OLLEYES. I use this at least 5 to 10 times a day, every day. I take it from one office to another. It weighs less than 2 pounds. It's got a nice little carrying case. We just hook it up to the EHR, run it on the system, and we get these great printouts, which literally are the exact same assessment as the Humphrey. It has the same blind spot assessment. It does 24s, 10s, 30s, screenings, Estermans. It does progression analysis, and it's about 1/4 of the price. So you might want to look at this. This is a great tool for compliance because patients actually enjoy doing this, and you rid yourself of the common problem we have, which is fixation. We're going to finish up with this, and we will be right on the moment. I want to talk about these devices. I happen to be blessed to have a partner who is one of the great glaucoma surgeons in America, Dr. Rob Noecker, and some of these slides are from him. The videos are our mutual patients. I couldn't get my videos to run, but let me just talk about what this does. As I said earlier, every conversation I have with a patient starts with, in glaucoma, I'm going to, in your lifetime, use a series of medicines and some surgery to make sure we keep your pressure under control. We're going to see you on a regular basis to make sure that we monitor the disease. We're going to do different tests at different times. And as we monitor those and we interpret them and we analyze them, I may need to recommend to you that we do something surgical now so that we can get your pressure down, or that we can stay on the medication. We'll see you back in this amount of time. But eventually, this combination is going to be a part of your life. What's happened is we used to have medicine, 1, 2, maybe 3 meds, then SLT, then if that didn't work, more medicine, maybe an oral medication, thank God that's gone. And then eventually trabeculectomy or 2. There was this gigantic gap between here at medicine and here at trabeculectomy. There was this black hole, which was all of that space in between where we watched the patient get worse. What's happened with MIGS, or minimally invasive, micro-invasive or minimally invasive glaucoma surgery, is, and if you're co-managing this, you know, we now have about that many, 3, 7, 9, 10, or 9, 11, 14, 13 or 14 different types of procedures that we do routinely every week in our office. My partner does probably 80, maybe close to 100 glaucoma surgeries a month. We have a huge glaucoma surgical referral practice on his side. So I get to see these almost every day. I saw 3 or 4 different ones today. And they are incredibly effective at choosing a level of care or control that maximizes your compliance, colleagues. Because here, in many cases, the patient does lose a drug or 2, sometimes 3. You get pressures at 15 or less consistently with maybe a single med or maybe no meds. And the balance of medication and these procedures done in either sequence or in some combination. Many of them can be done X, and then 2 years later, you can do a different one. The angle has many different places to approach it at. Has been unbelievably powerful in adding a level of compliance control that I never thought was possible. I've been treating glaucoma a long time. This has been an epiphany for myself and my patients, and I'm delighted to tell you that we have really slowed the progression of disease materially as a result of this addition to SLT, to the new medications, and to our overall understanding of how to help our patients achieve these goals. So just a couple of quick things. This is trabecular micro bypass. This is a eye stent. This is an eye inject. So this is a new one. There are 2 of these in the inserter there, and they're brought into the eye. This video is not running, but basically you can see the element there. This is actually the first generation. This is the original eye stent. It's placed into the trabeculum and then through the trabeculum into Schlemm's canal, and it provides outports. Those outports here in the study, this added about, probably about 30% to the control of, to the reduction of patients' medications versus cataract surgery. So it's about 50% greater than cataract surgery, 30% in real time. You can look at this as a 1-drug type of intervention. This is a hydrus. This is our most common. We use this with an Omni, which is a viscodilation of the Schlemm's canal. That's actually really important. Then this is planted in the eye, and there's the hydrus device right there. You can see it's just ready to slide through trabeculum into Schlemm's. It occupies 3 o'clock hours, and it widens Schlemm's canal, so there's this constant decrease in resistance. This is a good 1-drug to 1.5, maybe even 2-drug type of intervention. Excellent device. We love this one because it's that it's sort of advanced mild to most of moderate. Okay. And then here's the third one, which is another remarkable Allergan product called the Zen. This is the gel stent from Zen. This is a transscleral device. So it's inserted either from inside to out, which is called ab internal, or from outside to in, which is ab external. It just depends on the surgeon's preference. And what you're doing is you're creating a bleb, just like you would with a trabeculectomy, but with far, far, far lower risk of hypotony, macular pucker, choroidal effusions, and the usual concerns that we see with an overactive bleb. So the device is actually placed in such a fashion that you go cross chamber, you pierce through trabeculum, pierce through Schlemm's, out through the sclera, and then up under the conch. You clear Thimons capsule up under the conch, you release the element, and as soon as you do, it starts to blossom. Now that area has been pre-treated with mitomycin C, so you have good maintenance of the bleb. The only downside to this device that I've witnessed is in probably maybe a fifth of the patients, let's say about that on average, maybe a little bit less, maybe a sixth. The wound has to be revised periodically to reopen it because the bleb is not high. It's a very simple bleb. It's a very comfortable bleb, but it's not high. This will get you 1.5 to 2 meds and sometimes even 3 meds. So patient may be on a prostaglandin and a combo drug like Combigan, and we may get them down to none of those. They might drop to 12 or 13 without meds. I just had one of them today. Great time. Or they may get down from the prostaglandin and just be on Combigan maybe once a day. The goal is to use these devices to increase your compliance by decreasing the patient's reliance on self-administering medications. So with that, I am officially done.